Hello, I'm Dr. Kenneth Pearson. I graduated from Loma Linda University School of Dentistry in California in 1971 with a DDS degree and the Loma Linda University School of Health with a master's in public health degree in 1971 as well. After graduation, I joined the United States Air Force and was stationed in Colorado Springs, Colorado for 2 years. At the end of those 2 years, I was offered the opportunity to go to Africa as a dental missionary, which I accepted. I spent the next 17 years as a missionary dentist in Malawi and Zimbabwe. In 1990, I was invited to become a professor at my alma mater, the Loma Linda School of Dentistry, in the International Dentistry Department. All professors at the Loma Linda School of Dentistry are encouraged to practice 1 day per week, and so I went back to my first love and limited my practice to pediatric dentistry. I soon realized that there was a significant segment of the pediatric population that was not getting adequate dental treatment, usually due to management challenges, usually because of their young age or disability. So in July of 1992, I resigned from my professor position and entered the dentist anesthesia graduate training program. I completed my training as a dentist anesthesiologist in June of 1994. I began working as a dentist anesthesiologist in various pediatric dental offices until 1997, when I opened my own sedation pediatric practice in Visalia, California. In 2010, I opened Happy Bear Surgery Center in Tulare, California. This surgery center is a state-of-the-art facility and has received several accolades and has a good reputation in our San Joaquin Valley. I'm here today to tell you about halo crowns. With my love for children and pediatric dentistry, I sought to improve the appearance of pediatric anterior crowns. Children that require crowns are reminded of their teeth condition every time they smile, and I wanted to remove the social impact associated with children needing the restoration of their damaged anterior teeth. Furthermore, I wanted to improve the dental experience. I hoped that a patient could come in with a dark spot or a badly broken down front tooth and leave with a bright smile. And so I wanted to go through why I created halo crowns. My first desire was that the crown be aesthetic. Well, even more important than that it be affordable. I wanted that every patient should be able to afford to have an aesthetic crown, and so my next goal was to make it aesthetic. And of course, the most aesthetic crowns that were available to us at that time were the strip crowns. And the strip crowns were very aesthetic. However, they had some problems. They were very weak, and it was impossible for me to make them without leaving spaces. I had several parents who came to me and said, "I don't like those spaces between my children's teeth." But the weakness became a problem because I was having to redo them often due to fractures and breakage and so forth. And so my goals changed. It added a kind of a new requirement. I wanted something that was affordable, aesthetic, but I also wanted something that was strong. When I was in dental school, I remembered my training. We were taught how to make what we called window crowns or open face crowns. We would cement the crown into place, a regular ordinary stainless steel crown, and then using a high-speed handpiece, we would cut a window out of the facial surface, clean off all the cement, and replace that with a composite material. It usually gave us a good aesthetic crown that was very strong, but it took too long. By the time I got 1 or 2 of those done, most of my patients had kind of run out of patience. and they had lost their attention span, and it just was taking too long. So this added another requirement, and that requirement was that I wanted something that was affordable, aesthetic, strong, but also quick and easy to place. And by then there were some good veneer crowns out, and I started to use some of these good veneer crowns. And they were very aesthetic, and if there was plenty of room, they were pretty easy and quick to place, but they had some disadvantages as well. They were fairly expensive and many times not covered by the insurance. The veneers would chip and sometimes delaminate, and it was nearly impossible to crimp them if they were too wide, or if I wanted to crimp the edges to make them bond better. And so for that reason, they sometimes fell off. And then one of the big problems was that if they did delaminate or if they did chip, they were unrepairable. And so that prompted me to again add another requirement. I wanted an aesthetic, affordable, strong, anterior pediatric crown that was quick and easy to place, but I also wanted it to be retentive and repairable. In 1994, I got a patent for a pre-manufactured open-face crown, but I couldn't find any manufacturers who would make them. In 2018, I explained my idea to Rick White at Swiveller Pacific. He's an engineer, not a dentist, so I showed him all of the anterior pediatric crowns on the market. The first one I showed him is the ordinary stainless steel crown, and it's silver in color. They fit very well. They're silver both on the lingual and on the facial. They're strong, but they're just not very aesthetic. I also showed him the strip crowns, how they were made and how they could be placed. And I explained to him how they were not very strong and oftentimes broke and had to be replaced. Then I showed him the pre-veneered crown, and they're pretty nice. They're aesthetic. This is the way they look. They're strong, and on the lingual surface, they have metal, so they're good. But then I also showed him how they could delaminate and chip, and how they were unrepairable. By now, we had the ceramic veneer crowns. And the ceramic veneer crowns are very aesthetic. They're quite strong. In this model, we have two on the right, and then on the left, we just have two preps. But they're aesthetic because there's no metal showing, even on the lingual. But they also have some disadvantages, and that disadvantages were that they required a lot of reduction of the tooth, oftentimes requiring a pulpotomy or a pulpectomy. They are fairly thick and bulky, and many times they take quite a while because you have to fit the tooth to the crown. You cannot fit the crown to the tooth. Then I tried to explain to him the halo crowns. The halo crowns have a metal lingual, but a white facing, very much like a window crown. In fact, they are a window crown or an open face crown. I explained to him all of the advantages of the halo crown, how it had adapted the advantages of durability, aesthetics. They were quick and easy to place, they were very retentive, they were low cost, and they were repairable. I also showed him how they could really benefit the patients and the practice because of their value, and they were quick and easy, they were strong and durable, and we really got predictable results with using halo crowns. He was successful in figuring out a way to make them. So we now have the halo crowns available in every size. They're sized exactly the same as the stainless steel crowns, from 1 to 6 for each tooth. They're made by metal injection molding. Sometimes it's abbreviated as MEM. And this is a process where they're forced into a mold. They're then washed. They're then sintered, which means heated at a very high temperature. They are then washed and then polished and then inspected. And then we have a process where they are again inspected and automatically placed into packaging and used in this way to make them ready for sale. We have decided to introduce our halo crowns by packaging 3 crowns of the 12 most commonly used sizes on the 4 upper anterior teeth in a blister card. Of course, you know that the upper laterals can be used on the lower anterior teeth, although sometimes they require a size 1, which is not in the starter kit. Now, I'd like to show you a 3-minute video of some halo crowns being placed.
We start this case by examining it before any treatment is done. Tooth numbers D, E, and F all have mesial and distal interproximal caries. We begin treatment by doing incisal reduction using a diamond wheel, and then we proceed by doing the axial reduction using a straight diamond. We remove all the decay and reshape the teeth to accept the crowns. Our next step is to fit the correct size halo crown onto each of the prepared teeth. You will note that when the 3rd crown is fitted, it is crimped to be narrow enough to fit the space available. You will also notice that as the crowns are placed on each tooth, the gingival cuff of the crown presses on the gingiva and greatly reduces and in most cases stops the bleeding caused by the preparation. We now etch all of the prepared teeth by placing the etchant through the open window of the halo crown. After they have etched the appropriate amount of time, the preps are rinsed and dried. Again, notice the clean preps and the absence of blood. Bonding material is painted on the clean preps and light cured. At this point, the flowable dual cure material is injected through the open windows into the cavity between the prepared teeth and the halo crowns. Pay particular attention to the inset on the right side, which clearly shows the material flowing behind the lingual surface of the tooth and coming out on the other side. It is important that the lingual cavity or space between the prepared tooth and the halo crown is completely filled. All the overfilled halo crowns are light cured, and we begin to remove the excess hardened material, and the facial surface is reshaped with a straight diamond burr. Once all the excess material has been removed and the correct facial contour has been achieved, the facial surface is polished to a shiny luster. This enables the dentist to place durable, aesthetic crowns quickly and easily on badly broken down anterior pediatric teeth. They can be crimped and otherwise manipulated to fit nearly every situation, even when considerable space has been lost. Here we have the case before and after with the halo crowns in place. The crowns are fitted and placed so the dentist can confirm the alignment and arrangement prior to cementation. Since the prepared teeth are bonded to the crowns, the chance of failure of the crowns is minimal. The stainless steel lingual surface is not only strong, but it is smooth and kind to the opposing dentition without causing excessive wear.
By now, you're probably wondering, what material are you using to inject as a cementing agent? We think that there might be several dual cure flowable materials that would work. However, as we read about the various properties of the different dual cure flowable materials, we concluded that Activa Pediatric, made by PulpDent Corporation, had all of the properties we wanted. So it was one of the first ones we tried. We had such great success with this material that we have used it ever since. You'll have to realize that we're actually placing these halo crowns in actual patients, and we were a little concerned about experimenting with all different kinds of materials, especially when we were concerned about failures. So we have pretty much stayed with the Activa Pediatric, and it has given us great success. The clinical performance is pretty good. We have now placed over 1,000 of them. Most of these halo crowns were placed at the Happy Bear Surgery Center in Tulare, California. All of the Guardians were shown the different options, but most of them were given the option of a traditional stainless steel crown or a halo crown. Many of them were not of the economic status, or their insurance did not cover the more expensive veneer crowns or ceramic crowns. Patients with the remaining teeth after several months, many of the teeth have fallen out because of natural exfoliation, but we did recall as many patients as we could that still had the remaining teeth. And we were surprised that there were 0 complaints of any of the crowns falling off or becoming loose. And none of the Guardians expressed dissatisfaction for securing or selecting halo crowns over the traditional stainless steel crowns. Here in California, we build all of these halo crowns under procedure code D2933, which means that they were covered by the insurance. This was the little sheet that we used whenever we recalled a patient. On this day in December of 2021, we brought in 36 patients, which represented about 250 crowns, because several patients had more than one that were placed. And we examined them all, and we gave them a rating from 1 to 5. And as you can see, they all got very good ratings. We had one patient whose we were training a new dentist in our office, and the halo crown fell off during recovery. We don't know exactly why, and we don't know what happened. We don't know if it was inadequately cured with the curing light or something, so we had to quickly get that patient back in and replace that crown. But that was the only one that had a problem with stability and satisfaction and so forth. We had 4 crowns that had a slight staining along the incisal edge where the composite flowable material met the stainless steel. We were able to just polish that, and that staining was gone. I don't think that halo crowns will replace all other anterior pediatric crowns, but it is just another tool in your office to consider when you're faced with an anterior pediatric tooth that needs treatment. I'd like to explain to you when I think halo crowns are the best. The first is economic issues. When a patient cannot afford to get the more expensive crowns, but nevertheless they still want to get an aesthetic restoration. The second is a time when the patients have a very short attention span. As you know, the more aesthetic crowns take longer to place. The quickest crowns to place are probably the stainless steel crowns. However, we've shown that the patients with the shortest tension span, we can usually get the crowns placed and finished before they run out of attention. The third time when halo crowns are the best is when there's minimal tooth structure. As you watched in the video, you can see that the tooth is etched and the insides of the crowns are sandblasted so that they're rough, and so the material that is injected will bond to both the teeth and the crowns, and that's probably why we've not had any comebacks due to looseness or the crowns falling off. Another time when they're really useful is when the decay has been ignored for a long time and the spaces have been closing, and therefore there's minimal space. And the halo crowns can be crimped and squeezed and fit into minimal spaces. And the last time is when you have minimal caries, and so it happens to be on all sides of the tooth, but it's not terribly deep. You know, the expensive aesthetic crowns, like the zirconium crowns, require quite a lot of tooth structure to be removed. But because these are thin, just like a stainless steel crown, you can preserve that tooth structure, and you can place these crowns and restore the teeth with minimal tooth reduction and take care of all the caries at that time. I'm now going to show you some photos of actual patients before, during, and after treatment. The first patient already had 2 stainless steel crowns on the laterals, and we placed 2 more halo crowns on the centrals. The second case, we stopped and wanted to clearly show the placement of the flowable material around the lingual surface before we filled the facial surface. This is an important step in successfully placing halo crowns. The lingual space between the tooth and the crown needs to be filled before the facial window is filled. So I think that you'll recognize that this is a unique way of cementing crowns, which enables you as the dentist to make sure that all of the crowns fit and are aligned just the way you want them before they're cemented. And also, this technique provides the maximum retention, since the flowable material bonds both to the teeth and to the roughened inside surface of the crowns. I would like to encourage you to try halo crowns in your practice. I'm sure that you, like us, will find them a useful tool in treating your pediatric patients. The patients and the parents' acceptance has been very good so far. There have been no returns due to looseness or dissatisfaction, especially when compared with traditional stainless steel crowns. If one of them should chip or break, it would be easily repairable. I would now like to open the line so that I can answer any questions you may have.